Psychotic disorders. Differential diagnoses for psychotic disorders include mood disorders with psychotic features, schizophrenia and schizophreniform disorders, substance-induced psychotic disorders, delusional disorders, psychotic disorders due to general conditions, shared psychotic disorders, and psychotic disorders NOS. Other diagnoses that can be masqueraded as per psychotic illnesses include delirium patients often have paranoia with visual hallucinations, paranoid personality disorders, and schizotypal personality disorders can dance very near to the edge of psychosis. Obsessive compulsive disorders at times of obsessions can be difficult to discern from psychosis. Borderline personality disorders. When dysregulated, a borderline patient can appear paranoid and they think they can hear people talking trash about them. The most important thing to see is does the patient have prominent negative symptoms? Is the patient delusional or psychotic? And what is the nature of psychotic symptoms? Are they mood congruent, depressive themes associated with psychosis, or incongruent? Hallucinations are defined as the false sensory perception not associated with real external stimuli. Delusions are defined as false beliefs based on incorrect inference about external reality that is firmly held despite what most anyone else believes and despite what constitutes the incontrovertible and obvious proof of evidence of contrary. Always keep in mind the cultural norms. So it could be mood incongruent or mood congruent. Mood incongruent themes include the delusions of control, persecution, thought broadcasting, and thought insertion. Delusions or hallucinations consistent with themes of a depressed mood such as personal inadequacy, guilt, disease, death, reserve punishment. For manic mood themes worth, power, knowledge, and a special relationship to deity. So, come to psychotic illnesses, mood disorders with psychotic features. So, these are major depressive disorders with psychotic features, bipolar disorders, manic or mixed, uh, and schizoaffective disorders. Major depressive disorders with psychotic features. So, the patient meets criteria for major depressive episodes and also has the psychotic symptoms while depressed, and does not have the psychotic symptoms during the time of euthymia, and the psychotic features occur in 18.5 of the patients who are diagnosed with major depressive disorder. Mood disorders present at least a 2 weeks course of symptoms that a change from the previous level of functioning. The symptoms include the depressed mood, anhedonia, and four other including the depressed mood most of the day, weight changes, sleep changes, psychomotor disturbances, fatigue, poor concentration and thoughts, and death and worthlessness. Diagnosis: rule out any medical causes from the hypothyroidism, and most common is the neurological association of Parkinson's disease. And the first line of treatment is a selective serotonin reuptake inhibitor such as fluoxetine, paroxetine, sertraline, citalopram, or escitalopram. SSRIs are chosen due to their effectiveness and relatively mild side effect, and because they are less toxic in the overdose than other antidepressants. If some improvement is noted, but it is not the full response, increase the dose of SSRI. The psychotherapy, such as cognitive therapy, has been proven to be effective. The goals of cognitive therapy is to reduce the depression by teaching the patients to identify the negative cognitions and develop positive ways of thinking. SSRIs should not be taken with MAO inhibitors as they will cause dramatic increase in serotonin. The exceptions to SSRI use are uh, patient with depression and neuropathic pain, patient with depression who is fearful of weight gain and sexual side effect. Specific alternative to SSRI include the use of duloxetine. It is approved for both depression and neuropathy, and use bupropion since it has a fewer sexual side effect and has less weight gain than SSRI. May also be used as an adjunct treatment for SSRI-induced sexual side effects. Cornerstone of treatment is initiation of antidepressant but need for antipsychotic as well. Antidepressant antipsychotic co-treatment was superior to monotherapy with either drug class as an acute treatment of psychotic depression. ECT is very effective for psychotic depression, particularly in elderly and pregnant. ECT is a non-psychotic depression versus psychotic depression and found to remission rate of 95% in patients with psychotic depression compared with 83% of remission rate in patients with non-psychotic depression. ECT treatment with bilateral and the right unilateral electrode configuration can be superior to combination. Bipolar I disorder, manic or mixed disorder with psychotic features. The bipolar disorder is a mood disorder where the patient experiences manic symptoms that last at least 1 week and cause significant distress in the level of functioning. The manic symptoms include elevated mood, increased self-esteem, distractibility, pressured speech, decreased need for the sleep, and increased goal-directed activity, racing thoughts, and excessive involvement in the pleasurable activities. This disorder typically starts with depression, and one has to make sure that the condition is not secondary to drug use such as cocaine or amphetamine. So good history and clinical examination and urine toxicology screen is important. Difference between mania and hypomania has to do with severity of the symptoms, the level of functioning and duration. The manic symptoms last more than 1 week and functioning and severe enough to warrant the hospitalization. Hypomanic symptoms last less than 1 week and do not severely affect the functioning and are not severe enough to warrant the hospitalization. One must distinguish whether we are treating mania or bipolar depression. If acute mania, use lithium valproate. Atypical antipsychotics are the first line of the treatment. If bipolar depression, lithium lamotrigine is indicated. If acute mania with severe symptoms, consider the use of atypical antipsychotics due to shorter onset of action. If the kidneys are compromised, do not use lithium as it can cause damage to the kidneys. So, as discussed, mood stabilizers and antipsychotics are the treatment of choice. If they are not responding, we can also consider ECTs and mild catatonia, which is most commonly associated with bipolar disorder, is cornerstone of treatment is benzodiazepine. Schizophrenia. Schizophrenia is a thought disorder that impairs the judgment, behavior, and the ability to interpret the reality. The symptoms must be present for at least 6 months and it must be functioning. And there is equal incidence in men and women, but it affects men earlier due to the earlier age of onset, and urine drug screen is important to rule out the cocaine and amphetamine use. The types of schizophrenia include the paranoid, catatonic, disorganized, residual, and undifferentiated. For the patient, the only criteria need for delusion is bizarre or hallucination, consists of a voice keeping running commentary or two voices talking to each other, must cause a significant social occupational dysfunction, continuous sign of disturbance for 6 months, less than 6 months is a schizophreniform disorder. So paranoid type of schizophrenia is characterized by delusion or hallucination, mostly of the persecutory or grandiose type. The most common type of schizophrenia and has a later stage of onset. Catatonic is characterized by psychomotor disturbances ranging from retardation to excitation, and these include stupor, rigidity, excitement, and posturing. Mutism is common. Disorganized is characterized by marked regression to disinhibited behavior with little contact with reality, and patient typically appears disheveled and have bizarre emotional responses, and these patients also have worse prognosis and earliest age of onset. Residual type of schizophrenia is characterized by lack of positive symptoms, hallucination, delusions, but the presence of negative symptoms, flat affect, poor grooming, and social withdrawal. Undifferentiated are characterized by not meeting the criteria for other type. It affects 1 to 2% of population. Onset of symptoms in males peak 17 to 27 years. Onset of symptoms in female is 17 to 37 years. Only 10% of new cases have the onset after 45 years. Presence of proband with schizophrenia is characterized by the increase in the prevalence of schizoid and schizotypal personality disorder, schizoaffective disorder, and delusional disorder. Studies show that the monozygotic twins suggest approximately 50% schizophrenic has risk of genetic as there is 40 to 50% concordance. Estimated that 50% are due to yet of undefined environmental factors include the in utero exposure. Possibly due to the neurodevelopmental process such as increase in normal ages associated with pruning of frontoparietal synapses that occur in adolescence and young adulthood. Excessive activity of the mesocortical and mesolimbic dopamine pathway is also seen as the pathophysiology of schizophrenia. 57% of the schizophrenic patient met the criteria of drug or alcohol abuse or addiction. The odds of having an alcohol or drug use disorder is 6.5 times greater than the people with schizophrenia. That are the odds are for the rest of the population, and the odds for the alcohol use and disorders are over the 3 times higher, and the odds for the other drugs use disorder are 6 times higher. Negative symptoms thoughts are more debilitating in regards to the social and occupational impairment. 90% of the patients do not return to the pre-illness level of the social and vocational functioning, and 10% die by suicide. Generally marked by the chronic course with superimposed episodes of symptom exacerbation. One-third have severe symptoms of the social vocational impairment and the repeat hospitalization. One-third have the moderate symptoms and the social vocational impairment and occasional hospitalization. One-third have no further hospitalization but have residual symptoms including the interpersonal difficulties, and most cannot maintain the employment. So the treatment is to hospitalize the patient who are acutely psychotic, ensure that the patient's safety, and use the atypical antipsychotics such as risperidone, olanzapine, quetiapine, risperidone, aripiprazole, pantoprazole, acinipine, iloperidone, and lurasidone. In emergency situation, there is intramuscular injection is needed. Consider olanzapine, risperidone, haloperidol is still used. If non-compliant with the medication, consider using the long-acting antipsychotic medication such as risperidone as the first line of treatment. Haloperidol is still used but has more side effect. Clozapine is used when the patient do not respond to the adequate trial of the atypical to the typical or atypical antipsychotic, and never used as the first line of treatment. One need to know the differences in the side effect profiles of the atypical antipsychotic. It is common to have two appears um, commonly in the patient. Olanzapine can cause greater incidence of diabetes and weight gain and avoid in diabetic and obese patient. Risperidone, greater incidence in the movement disorders. Quetiapine, less incidence of the movement disorders. Risperidone, increased risk of prolongation of the QT interval. Avoid in patient with conductive defects. Clozapine has high incidence of agranulocytosis and need to monitor CBC on the regular basis and never use in the first line treatment in the given profile. The positive symptoms responds better than the negative symptoms. Antipsychotics are the mainstay of the treatment. Atypical antipsychotics used first to reduce the risk of the tardive dyskinesia, but can have the weight gain and metabolic syndromes, including the elevated lipids and type 2 diabetes. The risk of tardive dyskinesia approximately 3 to 5% per year for typical antipsychotics, highest in the older women with affective disorders, and risk of dystonic reaction are highest in young males. The schizoaffective disorders have uninterrupted period where there is a major depressive episode, the periods where there is delusions, hallucination present for more than 2 weeks without the prominent mood symptoms that meet the criteria for the mood disorders are present for the substantial portion of illness. The lifetime prevalence is 0.7%. The treatment of schizoaffective disorder is antipsychotic are the mainstay. If depressed, add antidepressant. Bipolar type mood stabilizers as well can be used. The substance-induced psychotic disorders can be caused by the alcohol, cocaine, amphetamine, cannabis, LSD, PCP, NMDA, and ketamine. Substance-induced psychotic disorder. If there is a prominent hallucination or delusion, there is evidence of history of physical examination or laboratory finding, and could be the symptom criteria A developed during, within a month, or the substance use etiologically related to the substance. The diagnosis cannot be made if the symptoms occurred before the substance or medications was ingested or more severe than could be reasonably caused by the amount of substance involved. If the disorder persists for more than a month after the withdrawal of the substance, the diagnosis is less likely with the exception of methamphetamines. Substances associated with inducing psychosis are alcohol, cocaine, amphetamine, cannabis, LSD, PCP, NMDA, ketamine, inhalants, and opioids. Treatment is stop the drug, chemical dependence treatment if indicated, consider antipsychotic depending on how the psychotic, the patient, and how long the symptoms have been present. Psychotic disorders due to general medical condition. It could be the brain tumor, seizure disorder, delirium, Huntington's disease, multiple sclerosis, Cushing syndrome, vitamin deficiencies, electrolyte abnormalities, thyroid disorder, uremia, SLE, HIV, Wellbutrin, anabolic steroids, corticosteroid, and anti-malarial drugs. Delusional disorders, these are the non-bizarre delusions involving the situation that occurs in real life, such as being poisoned, loved at a distance, deceived by the spouse, or at least 1 month duration. The criterion A for schizophrenia is never met. Apart from the impact of delusion, the functioning not markedly impaired, not due to the mood disorders or substance. Lifetime prevalence is 0.03%. Mean age of onset is around 40 years and slightly higher in females as compared to the males. So, disorder subtypes could be erotomanic, grandiose, persecutory, jealous, somatic, mixed. The brief psychotic disorder, the presence of one or more of the following: delusions, hallucinations, and disorganized speech, disorganized catatonic behavior. Duration of episode is less than 1 month of functioning. Psychosis knows if the patient has the psychosis but does not meet the criteria for any diagnosis. Differential diagnoses for psychotic disorders are the mood disorders with psychotic features, schizophrenia with and schizophreniform disorders, substance-induced psychotic disorder, delusional disorder, psychotic disorder due to general medical condition, shared psychotic disorder NOS, lookalikes could be PDP, OSD, PPD, and schizotypal psychotic disorder. So disorders with psychotic features are the leading diagnosis given with the depressive themes of psychosis, depressed mood, negative symptoms, no abnormalities in lab, normal physical examination, and lack of negative symptoms. Rule out diagnosis: the patient need to be currently meeting the criteria of a major depressive disorder and not have other reasons for psychosis, for example. So what information one would need to rule out the diagnosis? There is no history of manic episodes, no drug or alcohol abuse, no medical issues such as hypothyroidism or psychotic disorders, and do not meet the criteria of schizophrenia. So, how to approach a psychotic patient? Acknowledge you believe that they are experiencing what they are reporting. Try not to collude with the patient. Try to establish the rapport before confronting psychotic beliefs. Do not overly friendly, or it can feed into the paranoia. Psychotic disorders can be primary or secondary. Cornerstone of the treatment is antipsychotic if the primary psychotic illness. If secondary psychotic illness, treat the underlying cause and often will also need to use the antipsychotics. There are approaches as outlined earlier that can make interactions with the patient more effective. Thank you.